Okay, I think we'll go ahead and get started. Welcome everyone to the Technical Assistance Network for Children's Behavioral Health, Cultural and Linguistic Competence Peer Learning Exchange. The Peer Learning Exchange is a webinar or a monthly call with topics focusing on culture, health equity, and disparities in children's behavioral health. Topics are generated by you, individuals working in or being served by behavioral health organizations, and partnering with system of care states and communities. The TA Network, as it is known, is the National Training and Technical Assistance Center for Children's Behavioral Health for the Substance Abuse and Mental Health Services Administration, known as SAMHSA. Today's webinar is titled Lessons for the Field, Implementing Behavioral Health Equity Programs. My name is Kathy Lazier, and I am doing the introduction for today, and I'll be on the call. We're going to be discussing what we've learned over the past year from our work with system of care grantees related to implementation of culturally and linguistically appropriate service delivery, about meeting the CLAS standards, and about promoting behavioral health equity more broadly. Today's presenter is Catalina Booth. Many of you know. She is the Executive Director of the Center for Community Learning. The Center for Community Learning is focused on providing training, technical assistance, research, and program evaluation on issues affecting diverse and traditionally underserved communities. As a partner in the TA network, the Center for Community Learning provides technical assistance in the area of cultural and linguistic competence. Their expertise focuses around issues of language assistance, CLAS standard implementation, community capacity building, diversity and equity training, behavioral health literacy, and reducing behavioral health disparities. In her role as a member of the TA network, Catalina has focused her work on CLAS standard implementation and cultural considerations to reduce disparities and improve behavioral health equity. This presentation is being recorded, so your lines will be muted right now to help eliminate the background noise. So feel free to use the chat box to type in any questions or comments during the presentation. Following our brief presentation, we'll open the lines for further questions and discussions. So without further ado, let's get started, and I'll turn it over to Catalina. And I was
all right, thank you, Kathy. And I think the one thing that they wanted us to mention was that at the end of the presentation, don't log off immediately. Our technical guru from the University of Maryland will post a link to a brief survey that we would appreciate it if you take it. It helps us understand what we're doing well and what we need to improve. So I think that was the last thing to remember. Well, thank you everyone for joining us, and thank you for those that were planning on joining in August when this was originally scheduled for, who braved the schedule change. I'm excited about today's session because the purpose of today's learning exchange is to share the lessons that we've learned. So those of you that have worked with us throughout the year or those that have attended the CLC peer group meeting at the training institutes in Baltimore have helped us develop a lot of the content. So it might be familiar to some of you, but I'm glad to see by the phone numbers and the names that we have many people from many different fields and areas that have joined us. So we hope that today will be informative, but we also hope that we can exchange information and learn from each other through today's webinar. I know it's hard sometimes in a big group like today, and it's going to get even bigger as more people join in. So feel free to comment or join or discuss via the chat box, and at the end we'll have an open discussion, and we'll also have a few polls that will help us interact more. With that in mind, let's get started on the content. As we began to look back through this last year of 2017 to 2018, we talked about the most common TA topics or the most common topics of discussion in our CLC Behavioral Health Equity Roundtable, and 5 themes arose. They were the importance of engagement at representation at early and at all stages, the reality that organizational matters, and what I mean by that is that the reality is that the work of behavioral health equity requires collaboration and cross-sectional organizational structure, and so that how we do our work and how we organize our work is going to impact the effectiveness of our work. The third theme was the need to develop and use our behavioral health equity toolbox, and I'll touch on what I mean by that. But I think perhaps the biggest lesson, at least personally, was the need to dig deeper, and that we found that we're at a stage, many of our organizations are at a stage where we have gone beyond diversity, moved into cultural competence, and begun to dig deeper into what we term behavioral health equity. And we've begun to understand the relationships of how behavioral health equity permeates throughout organizations and what we need to do in order to dig deeper and make lasting change to reduce disparities and improve behavioral health of the children and families we serve. And the last key theme was the realization and our sharing to you that you're not alone. In the field that we work in, and particularly many of us focus mostly on CLC or behavioral health equity, sometimes it's a tough road, and we've learned that we're not alone and that working together really makes our work more effective. So we'll share some of those lessons. The primary lesson that we talked about, and when I started working on this presentation and thinking about key themes, it was, and I don't know if she's on, but Sharon Moreno from the System of Care in Texas was the one that reminded me of this, that engagement and representation should be first and foremost in everything we do, at every stage of what we do in the system of care and what we do as CLC coordinators or behavioral health equity champions. That buy-in and inclusion are foundational concepts because representation matters to health equity, and engagement and representation should be your first step and should be on your mind at each and every step. And just some research has shown, and these are all concepts that we know, but it's often good to remind ourselves. Bryson and Pullman wrote an article about what a difference family engagement makes in outcomes for children and families with behavioral health concerns. And it says the full participation of family members in planning, implementing, and evaluating services for their children with mental health needs is increasingly accepted as an essential aspect of planning and providing mental health services to children and families. The Surgeon General's report on mental health acknowledges family members are essential partners, both at the individual, child, and family level, and as key participants in system-level planning and evaluation. And that's really what a lot of us saw this year is that, and a lot of us learned, is that not just in terms of service delivery, but in terms of planning, creating our behavioral health equity plans, our CLC plans, family engagement and participation is necessary. And why? Because and Savage wrote in 2004 that by involving family and youth at all levels, a system of care assures itself that the culture of the system will be impacted by the perspectives and the cultures of the families and youth and community. And so I wanted to highlight one particular organization that has done this particularly well and has a good model of what engagement and representation is all about. And it is the Wisconsin Family Ties program. And parents of children and youth in Wisconsin with social, emotional, and mental health needs have run this statewide organization for more than 30 years. It was founded by a small group of parents, and they offer an array of services to families across Wisconsin, such as education, training, policy, advocacy, and support in navigating the various systems that families encounter. What's unique is that Family Ties educates others about how to best engage and work with families to help improve the lives of the children they serve. And central to their model of family engagement is the emphasis on supporting the strengths and abilities of parents. Early in the organization's life, they heard from parents that traditional models of family engagement that assumed parents needed training on how to parent their children were offensive and demoralizing. So Family Ties tried something different. They created a plan of engagement which focuses on empowering and supporting parents, flexibly working alongside them in areas of the parents' choosing, and everything from service delivery to actual system implementation and organizational matters. And so it's a model that I think we need to be reminded of, and we've been reminded of this year, that we need to welcome and invite parent engagement from the start throughout the process. And we need to shift our perspective, that it's not just in terms of developing the service plan that we have to include parents, but we need to include them in decision-making about organizational matters, from things like how to develop our CLC plans to developing our CLC committee, and having and creating spaces where we will listen to their perspective, we will accept their perspective, and we won't give up on including them and continuing with family engagement. That it's not a one thing. It's not, okay, I've created a family committee and I'm going to stop there, but it's going step by step and continuing with the work and furthering that engagement. The other lesson is that engagement and representation, it's not just about involving family and youth, but it's about engaging the larger community. And engaging the larger community can have incredible benefits. One example of this, and we shared this on a recent roundtable and a recent webinar, was Jacksonville System of Care. When they developed their Language and Communication Assistance Initiative, they came to the realization that language and communication were really tied to culture and being involved with community organizations. So they decided to build partnerships with diverse stakeholders, and it enabled the Jacksonville System of Care to identify what they call ethnic community-based organizations to form multicultural linkages with cultural brokers, allies, natural supports, and community-based multicultural resources. For example, the System of Care developed a teamwork and developed a task and started working with the Jacksonville Refugee Immigrant Task Force. And System of Care representatives attended monthly meetings to stay aware of new and emerging populations, changes in demographics in Jacksonville, and the impact of local and state national immigration policies. And it became a two-way relationship. Some members of the Jacksonville Refugee Task Force served on the System of Care CLC committee, and then in turn the System of Care referred some of its clients and its families to the refugee and immigrant families. And that allowed them to better serve the families and really address disparities that working alone would not have enabled them. And also, this partnership is an example of understanding that language assistance isn't just about, and representation isn't just about having people at the table, but giving them the services and the connections that are really going to enable them to participate. And so that was one example we wanted to share. Related to this topic is the realization that how we organize is really important because this work is difficult. It's not something that is accomplished. We do not reduce disparities in our first grant year. It's a marathon, and if we think of it as a sprint, that the entire CLC plan has to be in place and that we have to have all these things in place for month one, day one, that's not possible. It's a marathon, and we have to be deliberate about it. And in order for this to work and for this change to be lasting, we have to collaborate across systems to make lasting change and continue with partnerships for sustainability. And we have a poll question, right? Our first question is, in your system of care, what other systems do you collaborate with? And check all that apply. We have juvenile justice, schools, faith-based organizations, child welfare, colleges and universities, and other healthcare organizations. We'll give everyone a moment. We've got about 33 participants, and it'll take everyone a few minutes. Oh, and it will only allow us to check one. Okay. Is it fixed now so that they can check more than one?
Yes, it is.
Okay, good. It's fixed now, so you can check more than one. I will wait a minute more, and then I'll end the poll. We'll discuss some of the results. There's still a few more trickling in. I think we've got them all. I'm going to count. Okay. I'm going to end the poll so we can. Everybody got their votes in? Okay. Okay, it's closed for vote. So the 80% of us have worked in partnerships with juvenile justice, 90% with schools, 52% with faith-based organization, 90% with child welfare, 57% with colleges and universities, and 76%. So we are all doing that work, and we're all collaborating with other systems. The next question is an open-ended question, and I'll explain my wording. It's, what organizations have you had fruitful partnerships with? So what I'm looking for here is what organizations, like Jacksonville's example, they had a successful partnership with the Refugee Task Force that became a very productive bilateral relationship. So I'm looking here, if you can type in your answers, what organizations have you had fruitful partnerships with? So if you were from Jacksonville, you might say the Refugee Task Force. So if you could share, type in your answer in the open-ended question, you can go ahead and do that. We have so far schools, juvenile justice, a very good NAMI, give a few seconds here, colleges and universities, schools, another one for family assistant planning teams, so we have a broad variety of different organizations that people have collaborated with that have produced fruitful results in our work. And it's important, and some of these may give you some ideas of new organizations to deal with. And if anybody has questions about working with us, we can do that in our discussion. We can talk about how to initiate some of these relationships, so the ones that might not be as obvious as others to work with. We can, the poll. We could go back there. Thank you. All right. The next lesson I learned is that we need to develop a behavioral health equity toolbox. And over again, we found that a key tool in our behavioral health equity work is data. The collection of traditional data points such as race, ethnicity, language, preference, and sex, as well as other key data points such as sexual orientation, gender identity, and expression, economic status, social determinants of health are also crucial. And so here on this slide, I listed some data sources that go beyond the traditional data, data to more broad-based data that looks at social determinants of health in a variety of ways. And we looked at, what I mean by organizational data is that would be if you're a system of care working in a behavioral health organization, you would look at the data that you've gathered within your organization. Or if you work with a school district, if you're a school-based system of care, you would look at your data from your school district. Another source of data is census data. Casey Foundation Kids Count data is an excellent source of data on a statewide level. There's also a variety of child welfare data, criminal justice data, juvenile justice data, mental health and substance abuse data, special education, and gender identity and sexual orientation data. And I created for everyone, if we could, a resource list, and it's listed under Files to Download, and it is the August PLE resource list, Peer Learning Exchange resource list data sources. This first one, you can download that. And now I'm going to share my screen because I want to show you and highlight a couple of the ones that might be new to everyone. Can everyone see my screen that says Behavioral Health Equity Data Sources? I hope I can't see the chat screen now, so I'll rely on my co-presenters to let me know if they if someone can't see the screen. And someone speak up if they. Okay, all right. So the first one that I'm going to take a look at down here is for the. Okay, so if you open the downloaded one, the one what I want to highlight here is there's a variety of resources for you guys to look through and analyze, and a lot of them are statewide and nationwide. But one that I found particularly helpful under education was the U.S. Department of Education Civil Rights Data Collection, Wide-Ranging Education Access and Equity Data Collection. It's on page 2. It is the 4th resource listed, and it is the ocrdata.ed.gov. The reason I found this helpful is because this drills down to data on the number of English language learners, the racial and ethnic breakdown per individual schools. So if you are serving a school district, or if you're serving a county, you could get really good data on a variety of issues, even discipline data, and it goes all the way down to the school level. So I would highly recommend that those of you working in that area, or really any area, could find that to be a helpful information of helpful source of disparity data. And this is an opportunity for us to learn from each other, and since our lines are muted because we have a somewhat large group, we'll have to do this via the chat box. But what local data sources have you found helpful that I have not highlighted or mentioned here? If anyone has some to share, that would be great. Or if any of you have developed a good data collection tool that gathers more than just our typical data sources, that would be helpful too. Dawn, you asked for the links for data resources again. It is listed under files, under the chat box. There are files to download. And the August CLC Peer Learning Exchange is the slide. The third one is the August PLE Resource List data. If you click on that, you'll be able to download the PDF of all the data sources. And a lot of people are typing, so I'm going to let them type because I think we're having some. Kathy shared with us that the Williams Institute for LGBT data for individual states is also very helpful. Thank you. And Christine shared with us that we held a roundtable with community organizations and found their personal testimonies very insightful. That's another good way. Roundtables and focus groups can be a good source of information and also understanding needs assessment. That's an excellent idea, Christine. And we have a few more people typing, so I'm going to give them a chance to update. I know that in some communities have developed really robust data gathering surrounding what we term SOGI data, so sexual orientation, gender identity, and expression data, and have been able to roll that out. And that's one of the most difficult areas. So if any of you ever need technical assistance on that issue, please contact us, and we'll put you in contact with people to collect that data. New Hampshire Department of Education data sets were very helpful. Yes, and that's what that was my lesson learned, is that through the Department of Education, either at the state level or even at the U.S. Department of Education level, there is a wealth of resources beyond those of us that work with systems of care in school districts. Because of the type of data it is, it can give you a better understanding of, language, the cultures represented, the groups represented, and ethnic backgrounds at a really small level, because it goes down to the school level. So All right, I think as more roll in, we can share those through the chat box, but let's, in the interest of time, let's move on to our next slide. So I mentioned a behavioral health equity. One of the first tools is the data, which we just talked about, but the rest of the toolbox is really things that we already understand, but sometimes we don't package as a toolbox. And what I mean by that is that it's not, in our field, it's not just cultural and linguistic competence. We incorporate all these different aspects of it and form a toolbox and form a scaffolding that can inform and further our work. And those tools are the concepts of cultural humility and competence, health literacy, linguistic competence, and family and youth voice. What do I mean by that? Because I think that can, sometimes we hear those terms and we're like, I think I know what that means, but let's give a practical example. For example, say you work in a community that has a new refugee population from a country like Burma, and these are newly arrived Burmese, and they were going to be one of your populations of focus. How do you begin to serve them? How do you develop a behavioral health equity toolbox? Well, if you want to work in the field of cultural humility and competence, one tool you would have would be community organizations. You would look for a cultural broker or a cultural liaison that would help you understand and reach the population of focus that you're trying to reach. There are many populations where having someone from within that community is going to enable you to better address their needs and is going to better allow them to participate in services. So using the concept that we need to reach out and we need to use other cultural groups and other cultural organizations is what I mean by using our cultural humility and competence tools. The second tool in this case would be health literacy. So what do I mean by health literacy? Health literacy is the ability to communicate information about, in our particular field, is behavioral health issues and behavioral health conditions in a way that people will understand. So that tool, how would you adapt it to reaching your new population from the Burmese community? You would probably want to look at engaging families and engaging cultural liaisons or cultural organizations within the Burmese community to help you understand the best way to explain behavioral health concerns and what language and terms to use. For example, if you were reaching out to a Latino population, a Hispanic population, you might find that if you're translating into Spanish, using the term mental health might not be the most effective way to share with that population, but you would have to use terms that that group uses, such as in Spanish would be ataque de nervios, which is nervous attack. The different terminology is used in different communities, and you have to learn how to figure out how people describe what you're trying to get across and incorporate that into your work. Using the third tool of linguistic competence would, for example, in terms of your Burmese, the example community we're talking about, would be developing materials that are accessible in the language of preference for that community. And then family and youth voice would be something you run across the whole thing by incorporating family and youth into developing every aspect of the family. One comment that was made when we talked about implementing these four things is, how in the world do I do, this was from a new community with a new grant, how do I do this? I don't even know how to structure this in my behavioral health equity plan or my CLC plan. And what we found very helpful for communities was to take a look at the national CLAS standards and organize your work and organize your behavioral health equity work, your CLC work, according to the national CLAS standards. And actually, when SANSA does site visits, they look at your behavioral health equity plans, your CLC plans, and they are looking to see how many of the national CLAS standards are mentioned and how they are actually implemented. So having a plan that actually follows the national class standards is going to be a way to develop that toolbox and develop a way to implement all these aspects of behavioral health equity. We have, and we're going to send it out with an email with some resources, but we have a series, for those of you who are new to joining us and haven't been through the whole series of webinars, we have a series of webinars that the TA Network has done over the last 2 years that are basically the A through Z of national class standards. They'll teach you what they are, all the way to implementing them and using them as a direct clinical service provider. So we will be sure to send out links to those. They're found on YouTube, and you'll be able to access those. But I highly recommend those of you who have not gone through that series of webinars, if you need some help developing a toolbox or developing a way to further your CLC plans, your behavioral health equity plans, to look at those. Here comes the meat of my favorite part of today, is digging deeper. It was an eye-opening year for a lot of us, and it's been a difficult year for our country and for us in the field of mental health and children's mental health, and all of us and those of us that work with diverse populations. So as we planned for and conducted webinars this year, we kept urging participants to move beyond health equity, to move beyond cultural and linguistic competence, to making lasting change and reduction of disparities. And we kept coming across sobering statistics that vividly indicated that the effects of social determinants of health on behavioral health equity. What do I mean by social determinants of health? Where social determinants of health are everything that you see under that tree, everything from affordable quality housing to early childhood development, economic development, neighborhood development, justice systems, food sources. All of those affect mental health. And if we are not addressing mental health in the context of social determinants of health, we keep spinning our wheels. For example, the disproportional suicide rates among Black urban youth indicate a deeper cause for the larger number of suicides. And if you don't start looking below the trees to what's really going on in communities and affecting people, we will not further our work. And one way to further our work is by addressing these social determinants of health. And indeed, there's considerable and growing evidence that shows that mental health and many behavioral health concerns are shaped to a great extent by social, economic, and environmental factors. A review of global evidence by the WHO Commission on Social Determinants of Health reports convincing evidence that low socioeconomic position is systematically associated with increased rates of depression. Similarly, research in the U.S. has shown that exposure to adverse childhood experiences, another term for that is early childhood trauma or trauma throughout our lives, increases disparities. The Healthy People Initiative explains that our health is determined in part by access to social and economic opportunities. The resources and supports available in our homes, neighborhoods, and communities, the quality of our schooling, the safety of our workplace, the cleanliness of our water, food and air, and the nature of our social interactions and relationships. So if we're wanting to reduce disparities and we're wanting to be culturally and linguistic competent and really work towards behavioral health equity, we need to address these social determinants of health, and we need to work with the organizations that are addressing these social determinants of health. But how do we do that? And one thing that we do is we drop the silo mentality. We can no longer, I hate to use the word, but can no longer afford to work solely like our CLC work in behavioral health equity, to work that separately in a silo, separate from the rest of the organization. What I'm encouraged to see is that we have folks joining us here and folks who have partnerships with organizations in different fields, juvenile justice, child welfare, parent organizations. If our CLC work shouldn't just be in the CLC silo. Behavioral health equity work shouldn't just be in a behavioral health equity work. We should all be working together around a round table, so to speak, to really address social determinants of health. If we don't address them together, then we're not going to make lasting change. But in order for that to happen, we have to go even further. We have to do some difficult work, and that means we have to consider how unconscious bias affects the lives affects us as we work and affects the lives of people that we serve. And that means we have to engage in difficult conversations that will help us understand that the roles of bias and prejudice and how prejudice still exists and how even our words can create trauma. One of the realizations that we learned as we talked in the Behavioral Health Equity Roundtable was the importance of language. And I don't just mean translations and speaking in English and Spanish and Burmese and Japanese and Chinese, but really using language that bridges cultural gaps, not just among people from different countries, but also between adults and youth, or between different communities and different vulnerable populations, and that we really should use language that builds equity. Don Coy, who's a advocate for Native Americans, and he's the president and founder of White Bison, says that, it's a quote that really has stuck with me, which is, protest any labels that turn people into things. Words are important. You call it a flower if you want to care for something. If you want to kill something, you call it a weed. So that what that really means that words shape identity, and they help to establish cultural norms and definitions. Just as they have the power to distinguish between a flower and a weed, they have the power to give meaning to a person's identity. Therefore, we want to use bias-free language, and we have to realize that words can become a form of microaggression. What does that mean? Dr. Sue states that the brief and commonplace daily verbal, behavioral, and environmental indignities that communicate hostile or negative racial, gender, sexual orientation, and religious slights and insults to the target person or group. And why do I bring that up? And I bring that up because we're dealing with people, and we serve a community that is vulnerable, and we serve a community that has experienced trauma, historical trauma, and daily microaggressions. If we need to understand that, and we need to find ways to bridge those gaps. And one of the most useful ways to do that is to use what we call people-first language, which puts the person before their condition or before their status. And there's controversy. Some people and some young people like to identify by their condition. But I think what is important to remember, we can all agree on, is that we focus on the person and the individual rather than categories. We can help lessen the trauma from that. All right, and I want to leave plenty of time for discussion, so I'm going to go to the next slide, which is what we're here today. This work is often, we get isolated, and sometimes we feel like we're doing this work all alone. But the realization is that we're not alone. There's the community of people that attend this webinar. We're all in the same type of work. And if we share resources, we use learning collaboratives like this, and we share the hard stuff, we can learn from each other, and we can work, and we can make lasting change. And one of the ways that we've been able to do it this last year, which I really hope more of you can join us next year, is our Cultural and Linguistic Competence and Behavioral Health Equity Roundtable. It's a dedicated group of CLC coordinators, health equity coordinators, and behavioral health equity advocates who work within a system of care. And your title doesn't have to have any of those words are. Anybody who's a champion of behavioral health equity or cultural linguistic competence is more than welcome to our roundtable. And the goal of this group is to provide operational support and technical assistance to those working in this area of CLC and behavioral health equity for a system of care. And it provides an opportunity for discussion to address issues and that are of concern to its members. And we share best practices and ways to address challenges in the field. And it's an opportunity to learn from each other. And the conversation is driven by the topics that the members. So if you do want to join us, please send me an email, and it's on the chat box, and it'll also be in the follow-up email. And then my email is right here in the bottom. You can download the slides. I think we're ready to unmute the line. So if there are any questions. One sec, two. Well, yes, if you want to join the roundtable, send me an email so I can add you to the mailing list, and I'm going to be sending an email either tomorrow or early next week regarding our next meeting. The meeting on October 26th will be a chance for everyone to kind of get their feet wet, and also to learn what topics we want to learn from you, what topics you want to discuss this coming grant year.
Catalina, this is Kathy.
Yes.
I think that I just wanted to say that you touched on so many really important topics, and I think, as you said, they're all topics that you would want to dig deeper into. But I think one of the things is that you really touched on the importance of kind of addressing this at all these different levels of a systems level. What can you do around policies, and and then at the practice level, what kind of practice approaches are you using, and how do those kind of match up with what you're doing? I mean, if you're doing wraparound, or how does that match up with those CLAS standards and some of the policies that you have? And then you also talked about it at the very personal level, which a lot of this work is, and kind of the self-reflection that has to happen, and so much of the work that's being done now around the impact of microaggressions, I think, is really important. And I don't even think sometimes they say that the most damaging type of microaggressions are the ones that are unintentional. That we don't realize what we're doing when, if you're a white person and you're a white woman and you're walking down the street and you pass a black man and you clutch your purse tighter, or you cross the street not to pass their path. Those types of microaggressions, and the kind of impact that they have on kind of the psyche of a person. So I just, I think you did a really nice job of just touching on all of those different levels of, kind of how we have to approach this work at a systems level, at a practice level, and that at a very interpersonal level.
Yes, thank you for sharing that. There was a question from Kelsey whether the roundtable was different from the state CLC network calls hosted by the Georgetown. Yes, I'm not familiar. I've never participated with the state CLC network calls hosted by Georgetown. The CLC roundtable, there are members that are from some are state CLC coordinators, and others are CLC coordinators at the organizational level from all across the country, and it's different than that, yes. And it's like I said, the third Friday of every month. Any other, if anybody wants to share any unique work that you have done in addressing social determinants of health, that's also something that we're interested in learning. There's so much great work going out there that if we share with each other, people generate ideas, and we're able to get a lot further. Anybody want to be brave? So a lot of you are typing. So and that's what we've learned. A lot of people prefer to do the public chat. So I'll just wait for everyone to chat, and then I'll share with everyone what's coming up on the chat box. Do we have organizational assessments tool on CLAS Standards? Yes, we do. We will send those to you. Our technical guru will send me this chat box, this chat history, and we will send that to you. We will send links to that. We do have organizational assessments tools that are based on the CLAS Standards. We had a webinar that explained one of the ones that we've used, and I'll just briefly explain it. Broward County worked with Covey and Consulting and the TA Network to develop a CLC class assessment, and it was designed to see whether behavioral health providers were addressing the CLAS standards, and then it became a tool to help Broward County Behavioral Health Coalition help service providers develop their CLAS standards in their CLC work. And we've also done a webinar on how to structure your CLC plan based on the CLAS standards. So we will send out, which leads us to the last question, actually, which is that what cultural and linguistic competence and behavioral health equity topics would you like addressed in our peer learning exchanges next year? And type in your answers in the poll question. That way we can preserve them. And yes, I will send the link. One of the members wanted the link to the webinar organizational assessment tool on CLAS standards, and I will send that. I will send that to you directly, and we'll also do it with the email. Okay. One of the things that people have asked for us is resources for providers. What type of resources for providers? Is this behavioral health equity resources, or how to implement, how to use the CLAS standards? If whoever typed that in, if you could put in the chat box a little more clarification. CLC with trauma-informed care, how to conduct a comprehensive behavioral health disparity impact analysis, more community resources, okay. How to operationalize CLC and CLAS standards with the new system of care, using behavioral health equity impact statements, okay. Recurring themes. The good news for all of you is that we have addressed and already addressed a lot of these, and so many of you are new. We just need to remind you of what we have in the library, and then we will figure out which ones we want to update and dive in deeper. So I think language resources is another good one. I like this one. Resources on how to incorporate culture into assessment, service planning, practice, and respectful inquiry. Thank you. We actually did something, a webinar on that, but we need to dig deeper in that. We did one on how to use the cultural formulation interview, which helps incorporate culture into assessment. So I'm going to send out those, and we will use this to develop even more and dig deeper. If once I send these the library of our existing webinars out to everyone, it's also on the chat box, the YouTube playlist, but I have a written list, an explanation of each one of them, of what they cover, and I will make sure it's updated, and I will create that for everyone and send it out so that you guys can you can obviously look through the YouTube, but if you want links and explanations of individual webinars, I will get that sent out. And how to sustain the CLC work. Yes, that is going to be one of the emphasis of this grant year, is how to sustain not just CLC work, but general system of care, but definitely we're going to talk about CLC work and in that area. You say, how do we access the library? If you see right above your comment, Sonia, there's a link in a comment by the Institute. It's on a YouTube link. You could also Google TA Network. What's the best search I've done? TA Network, YouTube, CLC. If the link doesn't work or you're somewhere else. Any other questions or comments that people have, either on the chat box or to talk about? We're coming up close to the hour. I want to be respectful of everyone's time. Tiana, if you want to do the survey, I think we're probably ready for that. We have a couple people. We'll close out in a second. I think we have a couple comments and a question from Kathy, and then once I close. Okay, and thank you for reminding me, Kathy. Kathy put a link to the University of South Florida, which is one of the key partners and is the lead in the CLC group for the TA network. They have developed a library of CLC resources, including all the webinars, but also including a wealth of resources, not just from the TA network, but other sources on behavioral health equity and other topics of interest for CLC and behavioral health equity practitioners and champions. And the link is here. We'll send that out with the email too, and it's listed here under Kathy's comment. All right, I think that's it. So the link to the survey is in the presenter chat box, and it will, as I close out, the chat box, as we close the seminar, once I'm saying, then it will pop up, so please hit the link as the webinar closes out. And thank you everyone for joining us and bearing through us with the, through the technology issues, but I think we've all got the information, and I know that I've gotten emails from many of you. I will respond to them and add everyone to the list and send out information next week. And we have a couple last comments. Yes, Joseph, just I need you to email me. The only way I can add you is if you email me. So if anyone wants to join a Behavioral Health Equity Roundtable, I need you to email me at the email listed right here or in the chat box. And if you forget it and aren't able to do it now, it'll be in you'll get a follow-up email that will include that. All right, thank you, and we can close out for today. Thank you.
Thank you. Bye-bye.